Hello everyone, and welcome to our new podcast about the recently published monograph on asthma. I am Dorina Esendagli, the early career member representative, and I work as an adult pulmonologist at Başkent University in Ankara, Turkey. I am very glad to welcome here today the three guest editors of the monograph. David Jackson, he is a professor of respiratory medicine at King's College London, UK, and clinical director of Guy's Severe Asthma Centre. David's research has focused on understanding the mechanisms of severe asthma and EGPA, the pathogenesis of exacerbations of these conditions, and the usage of biological therapies to refine disease endotypes. Vanessa McDonald is a professor of nursing in the School of Nursing and Midwifery at the University of Newcastle, Calicut, Australia. Vanessa's research focuses on pioneering innovative strategies for the management of chronic airway diseases, particularly asthma. And we have Ian Pavord, who is a professor of respiratory medicine at the University of Oxford, UK, honorary consultant physician at the Oxford University Hospitals, and Ian's research interests lie in the clinical aspects of inflammatory airway diseases. Welcome to all of you. I would like to start our conversation by asking all of you, how did your journey in asthma field start? David?
I got into respiratory medicine quite early on after finishing med school. And this is not because I specifically chose respiratory medicine, it was just what I rotated to on the wards, and realized I really enjoyed this area of medicine. I enjoyed the different diseases within it. Asthma specifically was of interest because really, these patients, they become very sick very quickly, but actually can also make them better very quickly as well. And, generally speaking, a really interesting group of patients. And then as a junior doctor, I rotated to the Brompton Hospital in London, which was much more sort of focused on the severe end of the spectrum. And that I found really interesting and exciting. And it was a very challenging group of patients. And I thought, it was a very rewarding group of patients to work with and for. And then subsequently, I sort of, wanted to get into research, and it was a British Thoracic Society winter meeting. I remember it was back in 2007, and I was sitting in the audience listening to Sebastian Johnston, who was a professor of medicine at Imperial College, and he was always interested in viruses, and he gave it a really incredible lecture. And I thought, wow, this is really amazing. And I remember going up to him after his lecture, and he stepped down and introduced myself and said, I really want to do some research. Can I come and do it with you? And then he gave me like a 5-minute interview, and I started with him about 6 months later. And that's kind of how I really got into it.
That's great. Vanessa?
I ended up working in asthma quite early in my career. And I did that first by working on the wards, as David said, taking an interest in the patients in the respiratory ward. And following my first year in nursing, I was offered a number of positions, but chose to then go into the field of respiratory. So I've really been there since. And I guess in terms of my specialisation with asthma, there was an opportunity for me mid-90s to establish some asthma management services for ambulatory care patients in Newcastle. And that was to start a co-management clinic so that we could deliver asthma self-management education. I later established severe asthma clinic that followed on from that at the John Hunter Hospital in Newcastle. During this time, I was working purely clinically, but really evaluating the implementation of new services as I did that. And come mid-2000s, I became increasingly interested in research and thought, well, how can I balance a career of clinical practice and research, and began my PhD journey then, and have continued to work passionately with people with asthma to improve their lives from multiple different aspects and multiple different outcomes.
Thank you. And what about you, Ian?
I am interested in asthma for selfish reasons because I had asthma as a child, and my mother had quite significant asthma, and her mother died of asthma. So we had a strong family history of this. But another reason, important reason, as a medical registrar in Peterborough, and I will never forget attending A&E and seeing a distressed 14-year-old with a sheen of sweat brand new jeans on who'd wet himself, and he died of asthma in front of my eyes, and we couldn't rescue him. We just couldn't ventilate him. It was a completely avoidable death. And I remember talking to the mother who said, well, no one's ever been worried about his asthma. And this sort of disconnect between clinical expression of the disease and the risk of the disease, I think, has been a really important part of my work. And when I went to work with Freddie Hargreave, they were doing work there that looked to me like it would explain this paradox, this disconnect. We had to focus on airway inflammation as a key treatable trait. And that's really been a guiding principle since then.
These are all very impressive stories. And we see that asthma is actually with us for many, many, many years. It's just an old disease. But how could you define asthma in the 21st century? What are new regarding the definition and the understanding of the disease in the new millennium? David?
Has the definition fundamentally changed? I'm not sure if it has, but certainly our understanding has changed. And I think that, the journey that Ian describes, one of the reasons I wanted Ian on board with this monograph is because he has really led the way in moving us from an understanding that was not really based very much on inflammation and understanding asthma as an inflammatory condition to one that now clearly is. And, I think where we are now compared to where we were was understanding not only as this sort of branch of inflammation, which involves the eosinophils, which involves this type 2 inflammatory pathway, the dominant pathway, but also trying to, dissect that pathway further. And I think that's what's been so interesting about working in asthma in the last decade or more, is really sort of teasing apart that inflammation. And that's really actually, in many respects, only been possible because of the therapies we now have available to us, because we've been able to almost create these sort of knockout models in humans that allow us to take away just the IL-5 cytokine or just the eosinophil or target TSRP and see actually, well, this group of patients do unbelievably well and essentially go into remission, but actually this group still have active disease. And that is what remains actually for me so fascinating about asthma and why it remains so interesting.
Yes, and I've seen that there are a lot of chapters actually dedicated to the pathophysiology of the disease. So could you summarize how the monograph addresses the recent advances in asthma pathophysiology? Maybe, Jan, you could answer the question.
The monograph really takes the treatable trait approach. It looks at key processes. Vanessa and I have been very involved in the whole treatable trait area, and we passionately believe that this is the way to break down complexity and heterogeneity and to match patients to treatment more effectively. There's a lot on type 2 inflammation, a lot on biomarkers, because I agree with David, this is a key new understanding. This is in many ways, the airway equivalent of hypertension and hypercholesterolemia. It's a process that drives progressive disease, it drives damage, it drives dangerous events like asthma attacks. It's become clear that we have to make assessment of this process part of the routine approach to all patients with obstructive airways disease. And I've little doubt if that 14-year-old had his type 2 inflammation assessed at some stage, the high-risk disease would have been identified, and he would now be a 34-year-old with no real problems.
As clinicians, what is really crucial for us is to initiate an appropriate treatment to all these patients that we see, because sometimes we see that people that are classified as asthma are not asthma and sometimes receive such a treatment that is actually not needed. So, Vanessa, taking in consideration the new understanding of the disease, the new literature, and the pathophysiology, what should be the best approach for the diagnosis in our clinical practice, and what should the diagnostic process involve?
One really important issue is the underdiagnosis and misdiagnosis of asthma. So getting this right is crucial. And in the monograph, we actually look at diagnostic algorithms. One approach that's proposed is really looking at spirometry as the cornerstone for asthma diagnosis, but using complementary T2 biomarkers, particularly those who are in that highest pretest probability of having asthma. So using spirometry, complementing that with T2 biomarkers. But for those with kind of a low pretest probability, then potentially adding in challenges, methacholine challenge, indirect and direct challenges for the confirmation of diagnosis. But what's also really important there is actually ruling out those things that will often mimic asthma and complicate the diagnosis. And one of the comorbidities that we focus on in the monograph is ILO, inducible laryngeal obstruction, or otherwise known as vocal cord dysfunction, really depending on where you live in the world. But ruling out those kind of things that mimic asthma is equally important in terms of that diagnostic process.
Yes, I totally agree, because with an accurate diagnosis, then we could have successful treatment at the end. So that is the key. But I could say that asthma in itself is very heterogeneous. And with the new literature, we learned that it's even more complex than we thought about. So since we have such a heterogeneous disease, this make it difficult to treat all the patients properly by taking in consideration what we use nowadays, only the symptom assessment of these patients. So I've seen that there are many chapters in the monograph that especially address different treatment approaches for different patients. And at the end, actually, it seems that the individualized, the personalized approach is actually the one that we should do. So Jan, could you tell us about how could we implement this approach in our daily clinical practice? I mean, because we have a very specific time, we have many patients. It depends, of course, in the geographical area. So could this really be possible, or is it just like a theory?
Well, I mean, I think it's possible. And in the UK in November, we had radically changed guidelines, which put assessment of type 2 inflammation sort of front and center. And 50% of GPs in the UK have access to pheno. And of course, everyone has access to blood eosinophils. They're not difficult tests to do, and they're not expensive tests. They tell you a lot about risk. So I think it's very possible. One barrier, I suspect, and the reason that guidelines have been a little bit slow to adopt this, is there's been concern about not giving inhaled steroids to people with asthma who have low biomarkers. And I kind of understand that concern. A big push in the last 30 years is, we must use more inhaled steroids. The evidence of inhaled steroids, regular inhaled steroids, are helpful in people with biomarker low asthma is lacking. And I think the use of anti-inflammatory reliever, so an inhaled steroid with a rapid onset beta agonist, really removes this concern, because we've shown in the novel START study that biomarker low mild asthma does very well with anti-inflammatory reliever therapy. And I think if we make anti-inflammatory reliever therapy the backbone of our reliever approach, the debate moves on to who should have regular treatment and what should that regular treatment look like. And I think the point we make is that patients are different and you need different approaches. So, for example, if it's a biomarker low asthma with high symptom scores, are there relevant comorbid conditions like ILO, obesity, breathing pattern disorder? If it's biomarker high disease, are they taking their inhaled steroid? Is there anything we can do to help them to remember to take their inhaled steroid? And if we think they are, let's get them onto biologics, hopefully before too much damage has been done, because the main barrier to achieving remission on biologics is the presence of damage. David and I spend our working week looking after very damaged people where the opportunities for achieving remission are largely gone.
Can I add, I think, in terms of looking and implementing that individualized approach, we very much do that in a severe asthma clinic now. And one way that that is supported is through the use of a multidisciplinary team. So sure, the doctor might not have time to address all of those treatable traits that Ian mentioned earlier, but there are other team members that can deal with the obesity or the ILO, or very importantly, with the basics of asthma management. And Ian referred to that really devastating story of the 14-year-old person and said it was an avoidable death. And we need to think about not only treating the asthma itself, but ensuring we're treating it and patients have got optimal skills in order to do that as well. So one way of doing it, and it might differ from a different setting, whether that be a tertiary severe asthma clinic or a primary care clinic, is actually call on colleagues from other disciplines to help manage the overall patient.
I read in the monograph that it was mentioned that actually the group of severe asthma is not the group that has the highest mortality and morbidity. And maybe this approach explains the reason, because maybe we tend not to approach to the mild disease as well as severe disease, or maybe on the other side, the patients do not give importance maybe to their disease. And that is where we actually fail. And then we have such an increased morbidity and mortality at the end. You talked actually about the comorbidities, because in different airway diseases, we are not dealing with only just the disease, but we know that these patients are like packages. They have also other comorbid diseases. So, David, could you tell us which comorbid conditions do you consider most critical to address in asthma care?
Yes, well, the comorbidities are important in asthma for actually a number of different reasons. There are comorbidities, like Vanessa mentioned, like ILO, that if you fail to diagnose and identify, you will end up over-treating the patient with asthma therapies. And this is especially true if you don't use biomarkers to guide those treatment decisions. And all of us have met numerous patients who arrive in our clinics on enormous doses of prednisolone because the patient has symptoms that have not responded to therapies further down the treatment algorithm because those symptoms were never due to asthma. And the doctor assumed that because those symptoms didn't respond to high-dose inhaled steroids, that then they must need prednisolone. And because they didn't respond to 5 milligrams of prednisolone, then they must increase to 10 milligrams of prednisolone without thinking, actually, well, maybe the symptoms are due to something else, and that's why the patient's not responding. There are comorbidities like ILO, like breathing pattern disorder, like psychological morbidity, like severe reflux, that fundamentally drive symptoms that can mimic asthma. And unless you have a biomarker approach, often those can get missed, actually, because it's usually the low biomarker that really identify there must be something else driving the symptoms. On the other hand, there are comorbidities that really are associated with much more severe manifestations of asthma, like allergic bronchopulmonary aspergillosis, like EGPA, comorbidities that are important to identify because actually they really are very destructive and cause significant morbidity. And there are comorbidities that really help to identify the type of asthma the patient has, like comorbid nasal polyposis, and really identify patients who respond particularly well to certain therapies.
I've also seen that there is one chapter in Monograph about digital health, and it's a very hot topic. So, Vanessa, could you tell us what are the main issues that we will address in the future by taking in consideration the digital health approach?
Digital health can only enhance asthma management if we do it right. And there are a number of different ways that we can do that. Certainly within the clinic, with the health professional and the patient in terms of their communication and their identification of risk. Being able to communicate those things with patients, digital health can help pave the way for better communication around precision biomarker-led treatment. It can also help with that group of patients who have suboptimal asthma management skills, because using digital online platforms can actually allow more people to access that level of care to improve the skills that they have. So they're kind of, I think, very reachable aspects of digital management for asthma. But as time goes on, they will certainly actually become more and more sophisticated and be able to assist both clinicians managing asthma, but also patients dealing with their asthma on a daily basis.
Well, I'm afraid that we have come to the end of our conversation. So I would like to have from all of you a take-home message for our listeners. David?
Sure. Well, the three of us have worked really, really hard on this monograph. Until we sort of saw it in the flesh, we didn't realize it was a 500-page textbook. It really covers some of the most important, if not all the most important areas that really we feel will help physicians and multidisciplinary team members and sort of searchers who are interested in asthma. And going forward, if this is sort of like a side companion to those clinicians and scientists, I think invariably the quality of care of our patients with asthma will be improved, because it's really, I think, setting the stage for how best to approach these patients.
Yeah.
I think it's an enormously exciting time to be involved in asthma. We have this opportunity to get onto the front foot, to start thinking about disease activity, try and prevent downstream damage, which drives so many of the symptoms our patients have, and do things in different ways, offer precision medicine, the right treatment to the right patient at the right time. And it's the right time. I think we've got work to do. The book really does capture that, I hope. And I agree. I think there'll be something in it for all stakeholders, primary care, who really need to be familiar with, I think Vanessa calls them the super traits, the real key treatable traits that everyone needs to be able to recognize. Type 2 inflammation, airflow obstruction, breathing pattern disorder, poor treatment adherence, all of these really obesity, really important traits that we see all the time. So I think there's something for primary care, there's something for specialists, there's something for researchers. Yeah.
Vanessa.
I agree. I think it's currently a really exciting time to be working in asthma. We have new treatments, we have new paradigms like achieving remission. We're now talking about treating people earlier before the damage is done. So I think the future looks bright for asthma if we can implement these new ideas and continue to develop new treatments for people with asthma. I also think it's equally quite a frightening time for asthma. Despite all our advances in care, there are still really important areas that are not being particularly managed well. And they might be things like those basics of asthma care that we spoke of. So they really need to be prioritised as well, and prioritised from a funding perspective. The funding for research in asthma management is certainly not where it should be, but also the funding for clinical services is not prioritised like many other chronic diseases. So I think we really need to celebrate the exciting times in asthma, but also focus on the advocacy for improving outcomes in research and in clinical practice. I'm really proud of the monograph. I think it's really comprehensive. It's been great to be involved with the ERS team and with David and with Ian. And it's a great addition to your bookshelf.
I congratulate all of you for this enormous and magnificent work that you brought and for the nice conversation that we had today. I would recommend all our listeners to go and read all the chapters of the monograph if they want to take even more detailed information. Thank you for being here today, and goodbye.